Rickets and scurvy. Rickets. It occurs due to vitamin D deficiency, sunshine vitamin. Etiology dietary deficiency in fish, fish liver oil, egg yolk, drugs. Anti-epileptic drugs like phenytoin, phenobarbital, carbamazepine can cause rickets. Anti-tubercular drugs like isoniazid and rifampicin can cause rickets. It can be due to decreased sunlight exposure and it can be due to malabsorption of vitamin D. It can also be seen in chronic liver disease. Pathophysiology. Vitamin D deficiency can cause decreased absorption of calcium and phosphate. It can cause decreased mineralization of bone, weak bones, disproportionate short stature, short limbs, pathological fractures, and deformity. Cartilage hypertrophy at growth plate, osteoid expansion can cause swelling. Deformity, head, craniotabes, softening of skull bone, sponge ball, pong ball like consistency, increased size of fontanelles, wide open frontal bone bossing. Note: craniotabes can be seen in congenital syphilis, hydrocephalus, and osteogenesis imperfecta. Chest, costochondral junction widening, rachitic rosary, plain, painless and round, also known as string of beads appearance. Rickets chest, rachitic rosary, costochondral junction widening, Harrison sulcus. Harrison sulcus groove due to pull of diaphragm or on weakened ribs. Limbs, widening of the wrist, genu varum or bow leg, genu valgum or knock knees. Double malleolus sign, cartilage hypertrophy, swelling, and above lateral malleolus. Other findings: delayed dentition, seizures or tetany in infants due to acute hypocalcemia. Investigations: blood investigation, decreased vitamin D or decreased 25 HCC, hydroxycarboxylase. Due to decreased absorption, decreased calcium, decreased phosphate. Because of decreased calcium, increased parathormone, and there is the serum calcium level in rickets is normal. Serum calcium level in rickets is normal, but you have increased parathormone due to increased bone resorption by parathormone and due to increased ALP. Classification based on vitamin D levels, serum vitamin D levels. Sufficiency serum vitamin D levels nanogram per milliliter. Sufficiency should be more than 20, insufficiency 12 to 20, and deficiency less than 12. Radiological investigation, X-ray. Primary tool of diagnosis is X-ray. Loss of zone of provisional calcification, white line at the end of long bone. Splaying, lateral deviation of end, that's splaying. Fraying, first sign irregularity at the ends is called fraying. And cupping. Treatment: daily dose of vitamin D recommended. Duration is 12 weeks. Age less than 1 year, you give 2000 international unit per day. More than 1 year is 3000 international unit per day. Calcium supplement 50 to 75 milligram per kg per day. Monitoring response: X-ray. Preferred method shows changes by 4th week. Monitoring response is done by X-ray. Preferred method shows changes by 4 weeks. Healing with line of rickets, first visible sign. Biochemical investigation shows changes in 12 weeks. Refractory rickets, no response to vitamin D supplementation. Disorders seen: familial hypophosphatememic rickets, vitamin D dependent rickets, RTA associated rickets, chronic kidney disease associated rickets, familial hypophosphatemic rickets like X linked dominant inheritance. Most common inherited form of rickets. FAX gene mutation codes for phosphate regulation endopeptidase. Pathophysiology. Normal FAX gene mutation, no endopeptidase. Normal FAX gene, if present, causes it makes endopeptidase. It inactivates phosphatonin, fibroblast growth factor, FGF23. No endopeptidase, phosphatonin is always active. Increased phosphate excretion in urine, hypophosphatemia. Clinical features: lower limb deformities, no features of hypoglycemia, for example tetany, dental abnormalities like pulp exposure, increased risk of dental abscess. Treatment: phosphate supplementation, Julie solution, contains elemental phosphates. Burosumab, newer drug, monoclonal antibody against FGF23. Vitamin D dependent rickets, VDDR. Autosomal recessive inheritance, defects in vitamin D, metabolism, hypocalcemia. Clinical features of rickets. Additional features in type 2 vitamin D dependent rickets: ectodermal defects like milia, epidermal cyst, oligodontia, decreased teeth, alopecia. Resistance to vitamin D, type 2 metabolism of vitamin D. Treatment: type 1 alpha calcidiol, active form of vitamin D, and calcium supplements. Type 2 high doses of vitamin D, partially overcome resistance, improves symptoms. Approach to refractory rickets based on biochemical values. Serum phosphate high or low. Approach to refractory rickets, it's not responding to treatment, so you have to check for biochemical values, which is that serum phosphate high and low. If it's high, then it's a chronic kidney disease associated rickets, decreased excretion of phosphate. If it's low in arterial blood gases, then you check arterial blood gases in low phosphate. Serum phosphate, it's low. What do? Check arterial blood gases. If acidosis is present, renal tubular acidosis. If acidosis is not present, then parath hormone. You check parath hormone. If it's normal, it's called familial hypophosphatemic rickets. If it's high, responds to decreased calcium. It's vitamin D dependent rickets. So then if it is responding to decreased calcium and the parath hormone is high, then it is vitamin D dependent rickets. Scurvy, which is due to vitamin C deficiency. Role of vitamin C: collagen formation. Proline and lysine hydroxylation requires vitamin C, mature collagen. Second is wound healing, and third is osteoid bony trabeculae formation. Etiology: vitamin C deficient diet, food rich in vitamin C. Citrus foods, lemon, orange, green vegetables. Intake of boiled evaporated cow milk without fruit vegetable can cause vitamin C deficiency. Clinical features, early features, abnormal irritability, decreased appetite, anemia. Vitamin C is needed for iron absorption. Bleeding manifestation characteristics, gum bleeds, perifollicular bleeding plus corkscrew hair, bone subperiosteal bleeding, increased pain and pseudoparalysis. Child keeps his hips and knees semi-flexed, frog leg posture. Rosary, painful, sharp or angulated. Diagnosis, mainly clinical diagnosis, X-ray. There is subperiosteal hemorrhage. Area of rarefaction, poorly formed bony trabeculae. Ring epiphysis, white line of Frankel. Area of rarefaction, poorly formed bony trabeculae. Central zone and lateral zone. Central zone in area of rarefaction, poorly formed bony trabeculae is Sommerfeld's zone. And lateral area is called Palkin's spur. Treatment, oral vitamin C 100 to 200 milligram per day. That is oral vitamin C treatment 100 to 200 milligram per day, and duration is until lesion subsides. In the next video we'll see about genetic disorders.